Viewer discretion is advised. Some slides may have visual effects that aren't always suitable for all audiences. We use Emergency Medical Responder First on Scene for our Emergency Medical Responder course. We do not get paid to use this book, however, over the years, this course has been the easiest for our students to comprehend. Therefore is why we utilize it. This work is protected by the United States copyright laws and is provided solely for the use of our instructors to teach courses and assess the student learning process. This content on the website has been made available for our instructors to copy and distribute to our students in our classes as we see necessary. All education provided is a guideline to help you learn new concepts to better treat your patients. Your local protocol supersedes any education you learned in this course. You must always review with your medical director before changing your treatment plans that are outside of your local protocols. During this course, we're going to be going over the following objectives. Defining the following terms: altered mental status, behavioral emergency, clonic muscle activity, convulsions, diabetes, epilepsy, febrile and generalized seizures, hemodialysis, hyperglycemia, hypoglycemia, overdose, partial seizure, postictal, sepsis, status epilepticus, stroke, and tonic-clonic muscle activity. Explain the common causes of altered mental status. Describe the signs and symptoms of patient with an altered mental status, and explain the appropriate assessment and care for a patient with altered mental status. Describe the signs and symptoms of a patient experiencing a generalized seizure. Explain the appropriate assessment and care for a patient experiencing a generalized seizure, and describe the signs and symptoms of a patient experiencing a stroke. Explain the appropriate assessment and care for a patient experiencing a stroke. Describe the signs and symptoms of a patient experiencing a diabetic emergency, and differentiate between the signs and symptoms of hyperglycemia and hypoglycemia. Explain the appropriate assessment and care for a patient experiencing a diabetic emergency. State when it is most appropriate to contact the Poison Control Center. Describe the signs and symptoms of a patient experiencing an overdose poisoning. Explain the appropriate assessment and care for a patient experiencing an overdose poisoning. Describe the signs and symptoms of a patient experiencing carbon monoxide poisoning. And describe the signs and symptoms of a patient experiencing a generalized infection, also known as sepsis. Explain the appropriate assessment and care for a patient experiencing a generalized infection or sepsis. Describe the signs and symptoms of an allergic reaction. Explain the appropriateness and care for a patient experiencing a severe allergic reaction. Describe the signs and symptoms of a patient experiencing an emergency related to renal failure. Explain the special considerations that apply to caring for a hemodialysis patient, and describe the signs and symptoms of a patient experiencing a suspected behavioral emergency. Explain the appropriate assessment and care for a patient experiencing a suspected behavioral emergency. Demonstrate the ability to appropriately assess and care for a patient experiencing an altered mental status, and value the significance of an altered mental status as a sign of an unstable patient. In this section, we're going to talk about medical emergencies. Medical emergencies, they are caused by infections, poisons, or failure of one or more body organ systems. Signs and symptoms include altered mental status, abnormal pulse rate and rhythm, abnormal breathing rate and character, abnormal skin signs, and abnormal pupil size or response. So you need to ask yourself, when you're doing your critical thinking, why is altered mental status a medical emergency that demands attention? So think about it. What is going on in that person's body to give them that altered mental status? If they're altered because of a trauma, you can see that they're going to be altered because of a trauma, because of a head injury or a chest injury or significant bleeding. However, with a medical emergency, you can't do that. You can't see necessarily what's going on. You have signs that you can see. They've got symptoms that they can tell you. But with a medical emergency, you got a little bit more of an excitement going on, in my opinion anyways, because you're having to try to figure out, why are they altered? So now you're checking the box. Diabetic, yes or no. Stroke, yes or no. Overdose, yes or no. Multiple medical emergencies. Is it a poison, yes or no? So that's where I think medical emergencies tend to be a little bit more challenging than the trauma call. Some other signs and symptoms can be unusual breath odors, tenderness or rigidity in the abdomen, abnormal muscular activity, spasms or paralysis, bleeding or discharge from the body, pain, and shortness of breath. So when you're thinking of different things, what could be the cause of that unusual breath odor, and why is this significant in the patient with that altered mental status? If they have unusual breath odors, could it be because they are a diabetic and their blood sugar is, 500? Or is it because they drank something and they're poisoning themselves? And as you are trying to figure out what it is, you have to have these check boxes. You have to always ask that next question. And knowing and understanding what that next question is key. So when you're out learning, ask questions. Ask that veteran EMR, EMT, paramedic, ask them, why did you ask that question? What made you think about that question to ask next? And a lot of it is critical thinking. A lot of it is on your feet, critical thinking to get to the next level or get to the next answer, to ask maybe the next question, and then give them that answer, and then it's the next question. And so medical emergencies, again, you just never know what you're getting with it. So it's always asking questions. All right, so some more signs and symptoms: fever and chills, upset stomach and or vomiting, dizziness or feeling faint, chest or abdominal injuries, unusual bowel or bladder activity, thirst, hunger, odd taste in the mouth. So think about these. These are all vague complaints that you can have over a wide range of medical emergencies. Okay, they all relate to something. Some of these can relate to 5 or 6 or 7 or 8 or 10 different medical emergencies. So what is it? What is that one key sign or symptom that your patient is having that's going to push them to be more of a cardiac patient than an abdominal pain patient, or pushes them to be an overdose patient rather than a poisoning patient? Okay, so that's what you got to think about when you're listening to their signs and symptoms, is that 1 or 2 key things that are going to push them to something different than what you're thinking. During your assessment, you're going to take appropriate BSI precautions, complete a scene size up, which is starting at dispatch, perform your primary assessment, your secondary assessment, and any reassessments that if you have time. You're going to comfort and reassess that patient or reassure that patient while awaiting additional EMS resources, no matter if that's a BLS crew, an ALS crew, or maybe it's even a helicopter that you've called in. But your key that you need to remember for yourself is that you're walking into that house with safety in mind for you and your partner. If you feel like something is not right, you should not be walking into that home. Here's some things to think about. You respond to a single motor vehicle crash with a minor mechanism of injury. Your patient is unresponsive. What condition could have preceded the collision? Was it a medical emergency that happened prior to the collision that actually caused the collision? And how might the EMR proceed with this assessment and treatment in this case? Do you start with a trauma assessment or do you start with a medical assessment? So essentially what you're going to do is you're going to do a quick rapid trauma assessment, and if you don't see anything that is noticeable, then I would definitely say that is when you start your medical assessment to try to figure out what may have happened prior to the crash that may have caused that crash. In this next section, we're going to talk about evaluating mental status. During evaluating a mental status, anytime you have a normal mental status, that means they have a complete and accurate awareness of one's surroundings to person, place, time, and events. So what criteria are used to judge normal mental status in patients? That's these: the person, place, time, and events. And how might you determine this? So they know who they are, they know the people that are around, they know where they're at, the place of where they're at, the time it is, and then the events that were leading up to ambulance being called. Altered mental status is when the decreased patient alertness and responsiveness to their surroundings causes confusion or they are slow to respond. In this figure, you have a patient with an altered mental status, which is often confused and not aware of his surroundings. So it could be something like a diabetic emergency, a stroke, somebody who's intoxicated, an overdose, possibly a poisoning, something that they just cannot figure out their surroundings, or they're very confused as to where they are. Next is the Glasgow Coma Scale. It is a standardized tool to describe the level of responsiveness that EMRs, EMTs, paramedics, nurses, doctors, and so on, any type of healthcare professional would use to determine what their mental status is of the patient that they're taking care of. It's very useful in trauma and medical patients. The problem with this, though, is that what I think might be a Glasgow Coma score of 12, somebody else might think is 10. So when evaluating them on scene, you should have the first person that does the Glasgow Coma score and gives them the score. That should be the person that does it second and third and so on until another service arrives to transport the patient or they arrive at the hospital. During the Glasgow Coma scale, the scoring is the highest is a 15. The lowest score is a 3. So we always consider it as a tree is a 3. So meaning if their person is dead, they still have a GCS score of 3. Eye-opening is 4 points, verbal response is up to 5 points, and motor response is up to 6 points. And we'll see a figure here coming up to explain it just a little bit better. Okay, so here's a little bit better of a version of it. So in the eye-opening, if they're spontaneous and they're just opening their eyes, they get a 4. If they open their eyes during a verbal command, that's a 3. If they open their eyes when there's pain, with them, then it's a 2, and if there's no response at all, it's a 1. During the verbal response, if they're oriented and they have a conversation with you, they're a 5. If they're disoriented but they still talk to you, is a 4. If they're using inappropriate words, it's a 3. If they're incomprehensible sounds, moaning, groaning, grunting, whatever it may be, that's a 2, and no response at all would be a 1. During your motor, if they obey your verbal commands, meaning you tell them stand up and they stand up, that would be a 6. If there's localized pain, so if you do a sternum rub and they flinch or they push you away, that would be a 5. If they withdraw from pain or flexion, that's a 4. Abnormal flexion in response to pain or decorticate rigidity, it would be a 3. An extension in response to pain, the decerebrate rigidity, would be a 2. And no response at all would then be a 1. Common causes of altered mental status are trauma to the head, seizures, stroke, diabetic emergencies, poisoning, an overdose, and hypoxia. Common causes of altered mental status can also include shock, infection, trauma, psychiatric conditions, and liver failure. When you're out on the scene and you're checking all of these altered mental statuses and the possible causes of them, you need to get to the first, but the most immediate life-threatening causes and check those boxes and make sure that they're not having a stroke. They're not a diabetic that just needs some sugar. They're not a patient that's overdosing and they need some Narcan. Because those are quick, simple things that you can fix, but you need to start with the most immediately life-threatening causes first and go down your list. So here's some common causes of an altered mental status. So it could be medical or trauma injuries, heart rhythm disturbances and heart attack, dementia, infection, medication related, decreased blood volume, respiratory distress or disorders and hypoxia, hypothermia or hyperthermia, decreased blood sugar levels, and so forth. So here's just some common causes of them. Here's where you need to identify the exact cause of the altered mental status, but it can be very difficult because if you don't know, you don't know. What's around him? Could have he fallen off the roof? Could have he gotten hit by a car? Could have he, jumped out of that dumpster and fell and hit his head? But without any signs and symptoms and him not being able to tell you anything, you're pretty much at square zero, and now you have to build your puzzle. And so that's the problem with medical emergencies is it's always building from the bottom up rather than looking at it and taking the blocks off. Additional signs and symptoms can be confusion, seizures, inappropriate behavior, lack of awareness or surroundings, combativeness, syncope, which includes collapsing or fainting, and unresponsive. So why might combativeness be a sign of altered mental status? Okay, so let's think about this. The EMR needs to be very careful not to assume that a combative patient is simply just being uncooperative or that the underlying reason is always behavioral. Because essentially a diabetic who has a really low blood sugar could be combative, a person who has a head injury could be combative, a patient who just came out of a seizure who doesn't know where they're at or what's going on could be combative, somebody who's unresponsive who all of a sudden wakes up and doesn't know where they're at or doesn't know their surroundings could be combative. So there's a lot of many reasons why. So just be careful that you don't always assume that it's being that they're uncooperative or a behavioral issue. Assessing the patient. You need to focus on observation and obtain a complete medical history. Get their baseline mental status and use the AVPU scale, the alert, the verbal, painful, and unresponsive. Some things that we're going to talk about during the skills day is how would you assess a patient that is nearly unconscious and unable to communicate, and how would you obtain that medical history if they are in this situation? What happens if they're at home versus what happens if they're out in public? General treatment of altered mental status is to take BSI precautions and perform a primary assessment, monitor the patient's airway and breathing, administer oxygen as your local protocols call for, and monitor their vital signs. Additionally, you're going to provide emotional support, position the patient properly for comfort of care and protection of the airway. Do not administer anything by mouth and continue to monitor that patient while awaiting for EMS arrival. Next, we're going to talk about seizures, which is an irregular electrical activity in the brain. It causes sudden changes in mental status and behavior and uncontrolled muscle movements called convulsions. In a lot of the patients that you know for sure are having a seizure, their whole body will be jerking and convulsing, whereas other ones, it might just be their eyes twitching, it might just be their fingers, flickering, and some of them, which they call the absent seizures, is when they're in a blank stare. So these are going to be things that we're going to go over during our skills day. Generalized seizures, you'll have irregular activity through the entire brain. The patient's normally unresponsive and they'll have full body convulsions. Next is partial seizures, which is irregular activity in one section of the brain. The patient remains responsive, but they may progress to a generalized seizure. Causes of seizures can be epilepsy, which is a disorder of the brain, ingestion of drugs, alcohol, or poisonings, could be alcohol withdrawals or brain tumors. So what clue can you look for to determine if the cause of a seizure is an established diagnosis of epilepsy? Think about that one. Causes can be infections, high fever, diabetic problems, stroke, heat stroke, and head injury. Generalized seizures have a sudden loss of responsiveness. They report bright light, bright colors, or sensation of strong odor prior to losing responsiveness. They're having convulsions, and typically they will lose their bladder and or bowel at this point. So if they do have that, just remember that you want that empathy for them and that we take care of them as best as possible and don't judge, because during a seizure, you just don't know what's going on. Generalized seizure can be with labored breathing or frothing at the mouth, complaint of headache prior to or following the seizure. They can be in a postictal state, which is a phase of the seizure following the convulsions, where the patient's body completely relaxes and then vital signs return to normal. To care for that seizure patient, you need to move objects away from them, place something soft underneath their head. Do not attempt to restrain the patient or force anything into their mouth. You're going to loosen any restrictive clothing, including jewelry like a necklace. And after the convulsions have stopped, place the patient in a recovery position. But do not, I cannot emphasize this enough, do not put anything into your patient's mouth. And a bite stick that used to be years ago should never be used anymore. In cases where the patient may be having a seizure, protect the patient from any additional injury by moving things out of the way and placing something underneath their head. During a stroke, it's also a cerebrovascular accident, a CVA, or a brain attack. Obstruction or rupture of the blood vessels happen, blood flow to the brain is disrupted, and the portion of the brain does not receive adequate supply of oxygenated blood. So compare and contrast the difference between obstruction and rupture of blood vessels in the brain. Okay, So why is high blood pressure a major risk factor for a stroke? Well, the higher your blood pressure is, the more your vessels are going to have to work, and it could potentially cause a rupture of them or possibly an obstruction. With strokes, you have a window to restore that blood flow to the affected area, and that time is fairly short. So thrombolytics can reduce long-term deficits. So in rural parts of the states, you can actually give them thrombolytics at your local hospital if they carry them, and then fly them to a stroke center, and that is your best option. Any patients who are having a stroke that is a positive stroke scale, you should be contacting dispatch and getting a helicopter launched right away if they have not already auto-launched them. On here, you can see on the left side, you have the blockage or the cerebral vascular occlusion, whereas on the right side, it's a diseased artery that actually ruptures. Signs and symptoms of a stroke can be headache, syncope or fainting, altered mental status, numbness or paralysis in the extremities or face, difficulty with speech or vision, and confusion and dizziness. Why is it important for you to be able to determine the time the signs and symptoms began? Remember, they talked about that timeline. You need to get a stroke patient into a stroke center as soon as possible. So the longer you wait, the worse it's going to be. But there's some medications that you can't give, like thrombolytics, you can only give for a certain timeline. And so if it's over that timeline, you're no longer allowed to give them those thrombolytics. During the Cincinnati Pre-Hospital Stroke Scale, you're going to determine facial droop, arm drift, and abnormal speech. Remember that time is brain. A patient suffering a stroke may have facial droop on one side or the other. An inability to hold both arms up may be a sign of a possible stroke. During stroke care, you're going to take BSI precautions, perform a primary assessment, maintain an open airway, administer oxygen per your local protocols, and perform a secondary assessment obtaining the baseline vitals and the Cincinnati Pre-Hospital Stroke Scale. Why would it be important to updating the responding EMS agency that you suspect a stroke? Or do you have the ability to contact your local dispatch and have a helicopter auto-launched? For stroke care, you're going to place the patient in a position of comfort, provide emotional support, and perform frequent reassessments. Diabetic emergencies. Diabetes is a disease that prevents individuals from producing enough insulin or from using insulin effectively. Insulin is a hormone released by the pancreas. It allows glucose or blood sugar to enter the cells to be used as energy. The difference between type 1 and type 2 diabetes is type 1 is normally in kids or begins or starts as a child, and type 2 diabetes is typically as an adult. Here's the difference between hyperglycemia and hypoglycemia. Hyperglycemia, or high blood sugar, is a gradual onset. Causes of the high blood sugar is not taking enough insulin, eating too much sugar, and if untreated, hyperglycemia can lead to a diabetic coma. Signs and symptoms can be extreme thirst, abdominal pain, dry, warm skin, and rapid and weak pulse. Since hyperglycemia takes so much longer to develop, it is not encountered as often in the pre-hospital setting. It is more commonly found in patients with poor glucose control. But there are times that they can be in the pre-hospital setting and they will have that altered mental status. So again, as we're doing our vitals and whatnot, I highly recommend making your blood glucose just a normal vital signs check. Some other signs and symptoms can be sweet or fruity odor or the ketone breath, dry mouth, restlessness, and altered mental status, including coma, can happen with a hyperglycemic patient. Hypoglycemia, on the other hand, is a rapid onset. It causes some different causes of low blood sugar are taking too much insulin, eating too little sugar, overexerting yourself, or excessive emotional stress. So hypoglycemia is more frequently seen in the emergency setting, and these patients can be combative if their sugars are low enough, and they can be unresponsive. If they cannot swallow or they cannot speak or talk, These ones should not be ever given anything by mouth. They can have altered mental status, pale, cool skin, which is often moist, rapid and strong pulse, and dizziness. Why would low blood sugar cause an altered mental status? Think about that question. Why would low blood sugar cause an altered mental status? We'll discuss that later. They can also have headaches, shallow breathing, very hungry, and possibly even have a seizure. Emergency care for diabetic patients include taking BSI precautions, perform a primary assessment, a secondary assessment where you obtain a medical history, look for identifying medical bracelets, and find out if the patient has taken insulin or has eaten recently. Again, never ever give a patient anything orally if they have an altered mental status. Obtain your baseline vital signs and administer oxygen per your local protocol. If the patient is alert and oriented and is unclear whether the condition is hypoglycemia or hyperglycemia, you're going to administer oral glucose per your protocol or suitable substitute, either candy, orange juice, or regular pop. Some people work well with milk. But if the patient is not alert, you cannot, do not give them anything by mouth. Here's some things to think about before your skills day is 1, how might hypoxia change a patient's mental status? And 2, what steps might you take to immediately rule out hypoxia as a potential cause? So again, this will be in your skills, but think about that. In this next section, we're going to talk about poisoning and overdose. In this section, we're going to talk about poisoning. So poisoning is any substance that can be harmful to your body. Overdose is when the person takes in more medication than is normal. Narcan can help with overdoses as long as it is a narcotic form. So if it's not a narcotic, Narcan will not work. So meth, Narcan will not work on. We'll talk about that a little bit farther in the chapter here. Some routes for poisoning and overdoses can be ingestion, inhalation, absorption, and injection. So one thing you have to think about is which route of exposure might be the most dangerous to you when you're out on the scene. Obviously, you're not going to put something in your mouth that somebody gives you, but you could inhale it. The other thing that you could do is you could absorb it. So if you're going out to a motor vehicle crash and they happen to have the carfentanil or some type of drug out there, you could absorb it into your skin. Now, chances are you're not going to inject it yourself, but if you have somebody who's combative and so forth, they may inject you unintentionally or intentionally, or you might get a needle poke. So just keep in mind, the route that's most dangerous to you is probably going to be the inhalation and the absorption. So as far as Poison Control Center goes, it was historically marked toward the general public, but poison control centers are invaluable resources to responders. So if you are out on a scene of something, make sure that you contact them and have them answer your questions. There's currently over 60 regional poison control centers in the United States. What you want to do is you want to note and report any containers at the scene, check if the patient has vomited and describe that to them, and then check for any substance on the clothes or if the patient is wearing clothing that indicates a nature of work. For those of you who don't know the number to poison control, it is 1-800-222-1222. Utilize them. If you don't know medication from an ingestion of a liquid that you might not know to cleaning supplies, it is all over the board. So just give them a call and ask the questions. They're the professionals when it comes to poisoning. Some signs and symptoms of ingested poisonings can be burns or stains around the mouth, unusual breath odors, body odors, or odors on clothing or at the scene, abnormal breathing, abnormal pulse rate and rhythm, sweating, and dilated or constricted pupils. So some things to think about is what substance commonly is ingested in adults that pose a significant poison risk when ingested by children. Think about that for a second and think about an answer. So if you said alcohol, you're correct. So alcohol is a poisoning essentially, that's commonly ingested by adults, but it can be a huge poison risk when ingested by a child. So keep that in mind for ever going out to a scene. Some other signs and symptoms of ingested poisoning is excessive saliva, foaming at the mouth, burning in the mouth, the throat, or even painful swallowing. So a question that you should ask while taking the history from the patient who has been poisoned or has taken an overdose of medication is, was this an accidental or purposeful? Was it an accident, or did they try to ingest something that may help kill them? Okay, so that will also bring up the question of what other kind of mental health services do you need to get set up, or let the transporting ambulance service know so they can get those services for that patient. They may also experience abdominal pain, upset stomach or nausea, vomiting, possibly diarrhea. They can have convulsions or seizures, and altered mental status, including unresponsiveness. As far as emergency care goes, you need to make sure you're taking BSI precautions and perform a primary assessment. You need to ensure that that airway is open and they're adequately breathing. If needed, administer oxygen or assist with ventilations as necessary. Once all that is done, then you can move on to your secondary assessment, obtain as much information as possible about the specific substance, and call the Poison Control Center or medical direction for instructions. Poison Control Center has everything right at their fingertips, and they'll be able to tell you. They'll ask you different questions to ask the patients and so forth. So I just really want to push that if you do have a suspected poisoning or overdose of any sort, don't feel ashamed to call the poison control, because even myself, working EMS for 20 plus years and now doing education, I would still call poison control if I had a question, just because we don't deal with poisons, and overdoses every single day like they do. So they have those resources for you, and it just takes up a lot less time than you having to try to dig through a book or look it up on Google. With ingested poisonings, you do not want to treat them unless you're directed to by a physician or a poison control center. They're probably going to have you give them activated charcoal, unless, of course, they know what the poisoning is, and it may be worse for that patient if they vomit that up than to just leave it and let the process go. But if you do have to give activated charcoal, the adults is 20 to 25 grams, and the children are 12.5 to 25 grams as the dose. In case of vomiting, position the patient on the side or in a semi-sitting position with the head turned to the side to avoid aspiration. If possible, save vomit for a later analysis by the hospital staff. So what they vomit may determine, maybe there's pills that person took, and in that vomit there might be, 12 pills, and they took 15. So if you got 12 pills out of their system by vomiting, yes, there's still going to be some effects inside their body, but at least there's not 12 pills that are going to dissolve. There's only going to be 3. And so it might give them a different plan of action when they get to the facility, that they're going to, so they know what level they're at as far as their poisoning or overdose goes. Poisonings come in very colorful containers that are often appealing to children. So even though they have toy boxes full of toys nowadays, these kids are like, that's boring. I want to just go play with something under the sink or in a cupboard, or pots and pans and spoons and so forth, and make noise that way. But looking at all these colorful containers, they think that it's candy or toys or whatever, and really it's not, obviously. And so take that into consideration when you're going out there. It's maybe not that the parent did anything that wasn't right, or maybe they did do all the precautions, but kids can get into things no matter if we think they can or not. We put all these safety locks, safety devices on there, but kids for some reason can still get into it. So just keep that in the back of your mind. Okay, the next one we're going to talk about is inhaled poisonings. That comes from gases, fumes, vapors, or dust. Automobile exhaust systems, stoves, charcoal grills, industrial solvents, and spray cans are just some of the gases and fumes that you might come in contact with. This can cause shortness of breath, coughing, pulse rates of fast or maybe slow, and eye irritation. So think about this. You respond to a home for a lethargic child on a cold winter evening following a widespread power outage due to an ice storm. If you enter through the attached garage and notice a generator in use to provide some power to the house, you learn that not only is that child symptomatic, but her parents are complaining of headache and nausea as well. What are you going to suspect? Carbon monoxide poisoning would be the first thing I would suspect, but how do you proceed? If you're able to call those parents out with their children, have them bring them to you, get them out of that house, get them out of that environment, shut that generator off and open doors and windows and whatnot, okay? Just do not walk in. And I cannot stress enough how every call that you go in on, you should have a carbon monoxide detector with you so that if you ever get into that situation, you're not a victim before you know what's happening, okay? You can also get smoke inhalation from fires, which contains hot air and poisonous substances. It can cause burns to the skin, irritation of the eyes, burns to the airway, causing breathing problems, and potentially even cardiac arrest. When you do have smoke from fires, you have to think that if you have burns to the skin and irritations to the eyes and burns to the airway, how soon is your airway going to close up to where they actually have to do a surgical airway on you? So call for ALS, call for a helicopter, get whoever you can. If that patient is unresponsive, get an advanced airway in them right away. You can use an iGel, a King Airway, CombiTube, whatever your service uses as far as an advanced airway, go ahead and do that. Obviously following your local protocols. Next one is carbon monoxide poisoning. Again, it takes the place of the oxygen in the bloodstream. Some signs and symptoms include headache, dizziness, confusion, seizures, and coma. With this one, it's called the silent killer. I personally have an experience with carbon monoxide. In fact, my carbon monoxide level was extremely high. I was flown down to the metro area and was supposed to have been put in a hyperbaric chamber. However, when they asked if I wanted to go in, I declined because I would have had to be there a couple days, and I did not want to do that. I wanted to get home to my kids. However, when you're in that state of mind and you've got that bad of carbon monoxide poisoning, I really shouldn't have been able to make that choice. They should have made that choice for me because you're not in the right state of mind. You do get very blurry. You do get very, you don't necessarily remember everything that happened. I remember bits and pieces. I remember more after people told me about it than I would remember that part of it. But prior to that, I would not remember. So carbon monoxide is a very deadly and silent killer. So this is where we push so hard to make sure that your carbon monoxide detectors are working, you know how they work, and that if they do alarm, that you get out of the home or the building that you are in. As far as emergency care, move the patient to a safe area, perform your primary assessment, and administer oxygen and assist with breathing as necessary. This is where a non-rebreather at high flow oxygen, 12 to 15 liters per minute, is key, especially if you have the ability to check their CO levels and they're high. It is key to get them high flow oxygen and keep the oxygen going. You may end up using a bottle, 2 bottles, whatever it may be, but these people need oxygen, okay? If your patient is responsive, let him or her assume a position of comfort, obtain that baseline set of vitals, and monitor the airway and breathing status very closely. Again, it does not hurt to put oxygen on these patients, even if they don't have a high CO level. Just getting them something to get the rest of that CO out of their system is key. The next one we're going to talk about is absorbed poisonings. So signs and symptoms can be skin reactions with mild irritations to severe burns, hives, itching, eye irritation, headache, and increased skin temperature. Emergency care is to remove the patient from the source of the poisoning and then brush any powdered chemicals off the skin with a gloved hand. If you need to, you can take and put a mask on yourself, put a mask on the patient, so that if that powdery dust starts to blow up, that you are at least protected from it going into your airway and having now an inhalation issue as well. You're going to flush the exposed area with water, carefully removing all contaminated clothing, and then contact Poison Control Center or medical direction, and then make sure that you activate your EMS if it hasn't been already, but making sure that if it's something significant that you can get ALS en route or get a helicopter in the air to transport that patient to the closest appropriate facility for what's going on with them. Your small town local hospitals will be able to help stabilize them, but will not be able to, take care of them long term normally. All right, next you have injected poisonings. So the source can be insect stings, spider bites, stings from marine life, snake bites, hypodermic needle, or drug overdose or contamination. So here's something to think about. What if you respond to a public restroom, find an unresponsive male or female in the early 20s? He's turning blue and barely breathing. You notice that an uncapped hypodermic needle is on the floor next to him. What are going to be your concerns and how will you proceed? Is the first thing you're going to think about, oh, that patient's a diabetic, I better finish giving him his insulin shot? No, probably not. You're probably going to think, oh, here's another drug overdose. If you have Narcan, you can give it to them. If you don't have Narcan or your protocols don't allow, you can just bag them. Use a bag valve mask and bag them until a local EMS transport service arrives on scene, or if a law enforcement arrives on scene with Narcan, you can use that if they carry it, and so forth, okay? All right, so signs and symptoms are noticeable stings or bites to the skin, pain at or around the wound site, itching, weakness, dizziness, or they may collapse. So some things to think about is what signs and symptoms might you see with an allergic reaction, anaphylaxis, or a drug overdose? Think about that. Some other signs and symptoms you might see with injected poisonings can be difficulty breathing, abnormal pulse rate, headache, nausea, and anaphylactic shock. Emergency care for bites and stings would be to scrape away the bee and wasp stingers and venom sacs. This is going to happen with a plastic card, like a credit card. You don't want to be grabbing it with a tweezers. That's not it's not good. If they do have any venom left in there, you're going to squirt that in there. So do not pull out the stingers. You can place an ice bag or a cold pack over the bitten or stung area to help with that swelling and redness. As far as snake bites go, you want to flush the area with water, apply a pressure dressing, monitor the circulation, sensation, and motor function, and transport immediately. Snake bites are one you do not want to put a cold pack on. If you happen to get stung by a jellyfish, you need to neutralize the needles in the skin with either vinegar or baking soda and water. And then you can flush with hot water and use hot packs for pain relief. Next one we'll talk about is alcohol abuse. This can lead to illness, poisoning of the body, abnormal behavior, and even death. Some things that mimic it is diabetes, epilepsy, head injuries, high fevers, and other medical problems that can make a patient appear drunk. Intoxication may mask an injury or any additional medical problems. So why is it important to know the medical condition that caused a patient to appear intoxicated? If you think that they're just intoxicated, you might not take them serious, and then you have a problem on your hands, especially if they die in the back of your ambulance. Some signs of alcohol intoxication include odor of alcohol on the breath or clothing, swaying or unsteady, uncoordinated movements, slurred speech or inability to carry on a conversation, and flushed appearance with nausea, vomiting, or feeling the need to vomit. So something to think about. If you ever respond to a single vehicle, single driver, motor vehicle crash, your patient appears to have signs of alcohol intoxication, how do you proceed? Do you allow them to sign off if they feel like they're not injured? I wouldn't, especially if they're intoxicated. But the next thing I would do is grab a blood sugar to make sure that they're not diabetic. I would do a Cincinnati stroke scale to make sure that they're not having a stroke. And then you can actually ask them questions and find out, are they intoxicated? During alcohol abuse or after, you can have delirium tremens, or DTs they call them, high blood pressure, rapid heart rate, confusion and restlessness, abnormal behavior, hallucinations, tremors, obviously shaking of the hands are most common, and then convulsions and seizure activity. So delirium tremens are a result of rapid withdrawal of alcohol. So if you have a person who needs to take a drug and alcohol test in a week from now, and they know this because they've been given the courtesy, and they all of a sudden stop cold turkey and say, I'm not going to drink any more alcohol in the next week, but their body was so used to it, that's where they'll get those DTs coming from. So you're going to take appropriate BSI precautions, perform a primary assessment, a thorough secondary assessment to detect any signs of the illness or the injury. So make sure to monitor vital signs, stay alert for any respiratory problems, help the patient when he or she is vomiting so that the vomit will not be aspirated, and protect the patient from any further injury they may come in contact with. Okay, next we're going to talk about drug abuse. You have a few different, or 5 different ones. You got the uppers, which are, those are the ones that are going to excite that person. The downers, which are going to start to relax them. And then the narcotics, those are the ones that affect the nervous system and change many of the normal activities within the body. The hallucinogens or mind-altering drugs act on the nervous system to produce an intense state of excitement or distortion of the user's surroundings. And then the volatile chemicals give an initial rush, but then depress the central nervous system. So there's lots of different ones that they can get into. So what is it? Is it uppers, downers, narcotics, hallucinogens, or the volatile chemicals? With drug abusers, they may not be forthcoming with information that's critical for you to know. There might be a withdrawal from drugs that varies patient to patient and drug to drug. Signs and symptoms of use of overdose may mimic other medical conditions. You might find them shaking with anxiety, nausea, confusion, irritability, sweating, possibly increased pulse and breathing rates. So here's something to think about. How can a patient's fear of legal consequences impact the accuracy of information you can gather during your assessment? Well, think about that. If they don't want to get in trouble, they might not tell you that they're on any drugs at all, and now you've got a patient who's altered mental status and you don't know why. However, you may have given them Narcan to hopefully get them down off their high, but maybe it's not a narcotic. Maybe there's something else. Or maybe there was a narcotic and it was mixed with meth or, something different, and that Narcan's just not cutting it. So if they're not forthcoming and they're not telling the truth of what's going on, that fear can actually impact how we as responders care for them in the future. So as far as emergency care for drug abuse, number 1, BSI. Take your BSI precautions, perform that primary assessment, maintain an open airway and ensure adequate breathing at all times, administer oxygen per your local protocols, and then monitor vital signs and be alert for any respiratory arrest. So with drug abuse, you also need to talk to that patient, gain their confidence in you, gain that respect, make sure that if you're talking to them that they can continue to have that level of responsiveness, protect the patient from any further harm, and continue to reassure that patient throughout all phases of care. Explain to them what you're doing and why you're doing it, but it's always a good thing to think about, why is it a good practice to contact your medical direction or your local poison control center for a suspected overdose? Well, 1, because you're not doing this stuff every single day like they are. You don't know all these medications. And you know what? Honestly, after 20 years, if somebody comes up with something, to me, and I don't understand what it is, the first thing I'm doing is I am either contacting medical control or calling the poison control center. so that I know how to better care for that patient and not have to dig through Google or whatever and possibly get given the wrong information. Next one we're going to talk about is generalized infection or sepsis. So signs and symptoms can be fever, chills, rapid breathing, rapid heart rate, low blood pressure, and altered mental status. Remember in a previous chapter we had talked about compensating, your body was compensating for something else that's going on. This is exactly what I was talking about. So from a critical thinking standpoint, think about this. You respond to a boarding house where the landlord reports that a resident has been sick in bed for several days. You find a male in his late 40s lying supine under several blankets. The patient is incoherent and unable to answer your questions. You begin to assess vital signs and notice his skin is very hot. What are you going to do, and what are you going to look for, and how are you going to proceed with this patient? Okay, think about that, because that is one that we're going to actually talk about during skills. All right, so you also have infection that spreads to multiple organ systems through the bloodstream. The most commonly originates in the lungs, abdomen, or urinary tract. They again can have symptoms and signs of fever, chills, rapid breathing, rapid heart rate, low blood pressure, and altered mental status. High-risk patients include transplant patients, infants and elderly, radiation or chemotherapy, burn patients, diabetes, and AIDS. To care for sepsis, you're going to take appropriate BSI precautions, perform a primary assessment, secondary assessment, and then obtain a baseline set of vitals, administer oxygen per your local protocols, and perform reassessments as necessary. Moving on, we're going to talk about allergic reactions and anaphylaxis. So a reaction to an allergen could be mild reactions, are swelling of the skin and itching, whereas anaphylaxis is a life-threatening shock, which airways constrict and blood pressures drop. All right, so signs and symptoms of an allergic reaction or anaphylaxis can be burning, itching, or breaking out of the skin, breathing difficulty and rapid breathing, altered mental status, rapid and weak pulses, cyanosis of the lips and nail beds, swelling of the tongue and the throat, and restlessness. So what is the difference between an allergic reaction and a very severe allergic reaction? So an allergic reaction is something that you can probably take care of with Benadryl or an EpiPen, whereas anaphylaxis, there's going to be a significant more amount of medication that you may need to give. These patients are going to need to be transported into the hospital, possibly even flown to a higher level of care if needed, or taken by ALS ground ambulance. Again, review your protocols and your regulations for the EpiAuto-Pen. Okay, if your department is allowed to use that, you should be reviewing your protocols so you know if you're utilizing it the correct way. As far as treatment goes for anaphylactic or allergic reactions, you're going to take your BSI precautions, perform a primary assessment, ensure a clear airway and adequate breathing, administer oxygen as your local protocols require, and if unresponsive, look for any medical jewelry so you know if this patient may be having an allergic reaction and to what. If your protocols say you can assist the patient with his or her prescribed Epi auto-injector, you're going to want to monitor the vital signs and ABCs until EMS arrives. All right, the next one we're going to talk about is kidney failure. The kidneys fail to function normally at this point, no longer filtering the waste products from the blood, and your high-risk patients are going to include anyone over the age of 60, a history of diabetes, high blood pressure, a family history, or heart disease. So what is the emotional impact that dialysis takes on patients who are dependent on hemodialysis to survive? I can't imagine emotionally how that is for not only the patient, but the family that has to help take care of them. There's frequent dialysis treatments, sometimes 3 times or more a week. They can take several hours at a time and become a very big burden on the patient and sometimes even the family. So the patient will become discouraged. Maybe they'll skip a treatment or refuse to go. Unfortunately, if that is the case and that does happen, that's when those patients go downhill pretty fast. So these patients do need to take their dialysis every day that they are required to, or they can actually cause themselves more harm. You'll find patients that are going to be weak, altered mental status, generalized swelling, increased heart rate, increased blood pressure, and decrease in urination. During hemodialysis, they are mechanically filtering the blood to remove waste and excess fluid off the patient. Patients with renal failure must receive dialysis at frequent intervals. Surgically implanted shunts is what you're typically going to see with these patients as well. So you want to avoid assessing a blood pressure on the arm with the surgically implanted access point or the shunt. Typically it's found beneath the skin, and at that point you're going to need to use that alternate arm. They're very good at telling these patients, do not take a blood pressure on this arm. And so you may end up finding a patient who says, you cannot do a blood pressure on that arm. Believe them and listen to them. They're the ones that know their body well enough. All right, during hemodialysis, the dialysis machine is connected to an access point, typically a shunt, which is beneath the skin. So if you look on picture B there, a shunt can actually be clearly seen beneath the skin. So that is what a shunt will look like. All right, here's something to think about. You respond to a home to find an elderly female with fingernail polish on her fingers and around her lips. Her daughter reports that her mother suffers from Alzheimer's and ingested the nail polish. The patient is pleasant and cooperative. How would you proceed? She's patient, she's pleasant, I should say, and cooperative. But did she still have a problem going on? The answer is yes. She ingested fingernail polish remover, or fingernail polish actually. This should have a call to the Poison Control Center. In this section, we're going to talk about behavioral emergencies. Behavior is a manner in which a person acts or performs. A behavioral emergency is situations where the patient exhibits abnormal behavior that is unacceptable or intolerable to patient, family, or the community. So a question that I'm going to ask is, how might the signs and symptoms of a behavioral emergency be confused with a medical or traumatic reason for that altered mental status? Okay, so if you don't know what's going on and they have an altered mental status, that's going to be very difficult to determine if they're having a medical or emergency or if it's a behavioral emergency. During your assessment with a behavioral patient, you want to approach with caution, but do not approach the patient if it's not safe. You're going to observe for signs of agitation or violence, and if you do see that, you're going to step back. You're going to identify yourself and let the patient know that you are there to help them, and then inform them of what you are doing at all times. So what steps might you be able to take to de-escalate an agitated person? Sometimes it's you. Maybe you remind them of somebody. And the last thing you want to do is get them more riled up. Don't antagonize them. Don't keep pushing their buttons, because it's not right. You can also ask questions in a calm and reassuring voice. Don't be judgmental and allow the patient to tell you what happened. Show that you are listening by rephrasing or repeating a part of what they said, and be aware of your posture and body language. If you're standing over top of them and they're sitting on a chair and you've got your arms crossed and you're looking down at them, do you really think that they're going to trust you or be calm and reassuring with you? No, probably not. But if you get to their level within reasonable distance, they know that you're trying to get down there and you're being empathetic with them. So what specific questions might you ask to assess if the risk of suicide is there? I would ask them straight out, are you thinking about hurting yourself? And then start from there. And at that point, then let them answer. Again, leaving those questions as an open-ended question. If you do find somebody who is emotionally distraught, ask them or tell them what is troubling him or her, and encourage them to talk about it. Some want to, some don't, and that's okay. You're going to assess the patient's mental status. Always consider the need for law enforcement on any behavioral thing. Answer questions honestly and do not make quick moves. Treat people the way you want them to be treated. Treat them the way you want to be treated, and treat them the way your family should be treated. Do not threaten, challenge, or argue with them. Do not play along with their hallucinations or their auditory disturbances. Involve the family if it's appropriate, and leave yourself a way out. Always make sure you have an exit to where you need to go. Do not let the patient stand between you and your exit. Law enforcement officers may need to approach and control a patient experiencing a behavioral emergency before you can even go in there. If you feel unsafe, you back yourself and your team out and you wait for law enforcement to get there. When you're assessing for potential of violence, you want to do a scene size up, check for the history, watch their posture, their verbal activity, and their physical activity. Restraining them should be used as the last resort only. Sometimes it's necessary to protect your patient, yourself, and others. Just let law enforcement take the lead on that as best as you can. I'm not saying that if you're in a dangerous situation, you shouldn't stick up for yourself, but if you have law enforcement available, they should really be the ones taking lead on that. To summarize what we've discussed, conditions that cause the patient to experience altered mental status include seizures, strokes, diabetic emergencies, poisonings, breathing problems, and cardiac events. Presents with a range of signs and symptoms, confusion and dizziness to seizures and syncope. Assessment and care dependent on observing patient's environment and asking questions. Seizures, signs, and symptoms. Sudden unresponsiveness, convulsions, headaches, unusual breathing patterns, and clear around the area of the seizing patient. Stroke signs and symptoms are syncope, confusion, partial or full paralysis, headache, difficulty speaking or swallowing, altered mental status. Closely monitor for airway compromise, breathing difficulty, and cardiac arrest. Diabetic emergency signs and symptoms include difficulty or unusual breathing, abdominal pain, seizures, and dry mouth. Extreme thirst, fruity breath odor, altered mental status, and unresponsiveness. Hyperglycemia, which is the high blood sugar. They will complain of abdominal pain and extreme thirst and dry mouth. Hypoglycemia, or low blood sugar, will cause extreme hunger, may resist eating, will have strong rapid pulse, shallow breathing, possibly seizures, and pale, cool, and moist skin. When EMRs cannot determine if a diabetic emergency is caused by hypo or hyperglycemia, care should be the same. You're going to administer real sugar, provide oxygen, and activate the EMS system. Monitor the patient's ABCs and make them comfortable. Signs and symptoms of poisoning can include altered mental status, vomiting or abdominal pain, sweating, abnormal pulse and or breathing, unresponsiveness, pain when breathing or swallowing, dilated or constricted pupils, and weakness or dizziness. Carbon monoxide poisoning can cause headaches, dizziness, confusion, seizures, and coma. Primary indicator is patient surroundings. If the patient presents with signs and symptoms and has been near any sort of combustion, suspect carbon monoxide poisoning. Care for poison or overdose patients, you need to protect their airway, administer oxygen, activate the EMS system, monitor their ABCs, and local, regional, or national poison control centers should be contacted immediately. Sepsis is a condition where a once isolated infection spreads through the patient's bloodstream and becomes a system-wide problem. Indicators include fever, chills, confusion, unresponsiveness, rapid breathing, rapid heart rate, and low blood pressure. Septic patients must be treated at a hospital. EMR should activate the EMS system, provide oxygen, and monitor patients' ABCs according to your local protocols. Anaphylaxis is a life-threatening allergic reaction. It can cause altered mental status, difficulty breathing, swelling of the throat, support their ABCs, and assist with prescribed autoinjector if available and if your local protocols allow to. Renal failure is when kidneys no longer function normally. Dialysis is artificially filtering blood and removing excess water and waste products. Behavioral emergencies. A patient is behaving in a manner that is intolerable to himself or herself, his or her family, or their community. You should ensure that their own safety and safety of others when near the patient. Clearly and calmly identify themselves to the patient, ensure EMS systems activated, and engage the patient with clear, effective communication.